So good morning to everyone. So today's session will be on complications of hepatitis. So I can't go extensively about every single complication because it's for lack of time. We have a 30-minute session. So I'll briefly talk about acute liver failure for about 10 minutes, and I'll briefly talk about how to manage difficult upper GI bleeding. So these are the two complications that I'm going to talk about. There are obviously lots of other things that you can think of. But for lack of we can have those extended sessions later. So this will be an interactive session. So what I'm going to do is ask all of you to join. So this is a question, so I'm going to first start with the question. So this is a case of acute liver failure, which is what we're going to talk about. So acute liver failure. A 60-year-old man presents to hospital with malaise, nausea, and jaundice, increasingly confused only today. He has mild tachycardia and jaundice, and the last blood tests done 3 weeks before were normal. And these are his blood tests. So I want to repeat the question. The answer is in the question. So I'll repeat the question again. So it's a 60-year-old man who's had jaundice since 8 days and today has a bit of confusion, which the local physician thinks is probably some level of encephalopathy, and there is some liver dysfunction in the blood tests. So the question that we have for you is, what type of acute liver failure is this? I think it's getting logged out, so that's fine. So what type of acute liver failure is this? I want some responses so that I know what type everybody is thinking. So do we have any answers or hyperacute? So I've clearly mentioned that the jaundice is 8 days before. So jaundice to encephalopathy time is more than 7 days. So your point is right, Dr. Homdar. This is acute liver failure, but this is not hyperacute. Hyperacute should be within 7 days, and this is acute liver failure. So acute liver failure will be day 8 to up to 28 weeks. So this is hyperacute liver failure, and more than that is obviously subacute and chronic liver failures. So this patient, the next question is, what is the treatment you want to start immediately? So you've diagnosed this problem that there is acute liver failure. What is the treatment you would like to start? Okay. What is the treatment of choice for acute liver failure? So that's what I'm asking. It's a very direct question. If you have somebody with acute liver failure, is there any specific treatment option that you have for acute liver failure itself? I'm not asking for hepatic encephalopathy. I'm not asking for chronic liver disease. Somebody's written supportive. That's a very good answer. So apart from normal supportive care, for example, if the patient is drowsy, GCS is less than 8, you would obviously go for intubation. So that is very important. So that's a supportive care. The patient might have respiratory problems. That is, they may have ARDS, they may have pneumonia. So that needs to be, finally, we have the exact answer. Dr. Ranjit has said NAC infusion, and that's the answer I was looking for. So supportive care will include care for the ICP, that is care for the brain, because they will have cerebral edema. So regarding cerebral edema, we will come to it again, but that is a very good answer. So the first treatment that you will initiate while doing some investigations to check all the other organ systems will be a NAC infusion. It is called N-acetylcysteine. So N-acetylcysteine, there is a specific dosage for paracetamol overdose, but the dosage for people with acute liver failure is the same. It will be 150 milligrams per kilogram for 24 hours. And this dose needs to be continued till their acute liver failure resolves, which can be indicated by falling AST levels or INR levels coming back to less than 2, and the patient's clinical encephalopathy improving. So NAC infusion is the answer I was looking for. How does it work? So when liver fails, glutathione stores get depleted. So these needs to be replaced with N-acetylcysteine. Otherwise, they will go and cause liver injury. The next problem that we need to tackle with in acute liver failure is this. Yeah, Dr. Aarti asked, why not glutathione? Glutathione is contained in N-acetylcysteine. That's what it will go and produce. So it's basically you're giving some glutathione. So we don't have that. Anyways, so for the next image, can everybody write down on the chat box what do you see on the image? I can see your chat box now. I think the Slido is not working, so that's fine. Skip the Slido. Just go to the chat box. Tell me what you see on the CT scan. There's a CT scan of the head, and there is something very obvious that you can see. I've got one response saying cerebral edema. Does everybody agree? Can you just type in as well? Is this cerebral edema? Just say yes or no. Yeah, so we have some yeses as well. That is correct. So this is clearly cerebral edema. You don't need to understand CT heads. Obviously, most of you are physicians and we don't need to understand them very well, but this is a very obvious cerebral edema where you can't see the, the sulci and the gyri in the corners. There is no black little spots in the corners, which is very it's one of the most obvious cerebral edema CT scans you will see. Mostly at the bedside or patients who have encephalopathy, you might not see such a nice image, but this is cerebral edema. So my next question is, what are the principles for treating cerebral edema? Can somebody just try to do the poll? I'm not sure if it's working or not. If you have it on your phone, the slido.com, just see if you can tick the boxes here. You can see the answers live. Anyways, I've given some options here. So again, the question here is, what are the treatment principles? The treatment for raised ICP is what is being given you. I think you guys have said 3% saline and mannitol, which we'll come to after this question. So the basic principles remain the same. Before you start on treatment like mannitol or hypertonic saline, head elevation to 30 degrees, sodium levels of 145 to 155, and somebody has correctly pointed out that 310 millimoles, the osmolarity should not be more than 310 millimoles when you're giving mannitol. That's very good, Dr. Surinder. With answers are coming up now. I think head elevation, sodium 145 to 155, cerebral perfusion pressure of 50 to 60, and PCO2 of 30 to 35. Are all these answers correct? So many of you, this is a multiple choice question, so you can mark multiple points, whichever is correct. And as you can see on the image, you can see that most of you think head elevation is correct, which is right, because head elevation will help to drain the cerebral vessels. Sodium 145 to 155 is again correct. That is the number you need to sort of treat to maintain the sodium balance across the brain and prevent the edema from worsening. The cerebral perfusion pressure. Now I've written cerebral perfusion pressure of 50 to 60. I'm not sure how many of you have worked in intensive care. So cerebral perfusion pressure is given by the formula called mean arterial pressure minus the intracranial pressure. So if intracranial pressure, we can use the central venous pressure as a sort of marker of intracranial pressure. So the cerebral perfusion pressure equals mean arterial pressure minus the central venous pressure. This should be 60 to 70. So this question has specifically framed just to make you remember that the cerebral perfusion pressure should be 60 to 70. And normally with cerebral edema, the intracranial pressure goes up to 20. So the mean arterial pressure should be maintained more than at least 80 to 90. So this is important because your blood pressure level should be a bit higher for cerebral protection with cerebral edema, even in acute liver failure. So that's an important point I wanted to point out. PCO2, that is carbon dioxide level, should be maintained between 30 and 35, but that only works for the first 24 hours. Coming to the main treatment of raised intracranial pressure, which is, as many of you have mentioned, hypertonic saline and mannitol. In our center, we rarely use mannitol simply because it adds one more step to the management where you have to keep checking the osmolarity. What we usually use is hypertonic saline boluses. So if there is a very massive cerebral edema and we think we do not have the time to manage the other numbers, we first give an initial bolus of about 100, that is about 2 mils per kilo of hypertonic saline, 3%. And then start an infusion of hypertonic saline. So the infusion will be based on the sodium levels more than anything else. So just maintain the sodium levels, make sure it doesn't go up too quickly, and get to the levels quickly. So that's what we're trying to do. The other treatment like mannitol we rarely use. Is there any other treatment options that you have to decrease the intracranial pressures? All of you have mentioned mannitol and acetazolamide. All of you have given a lot of options in the question as well, where you obviously thought it's a single best answer. I think that's why most of you have chosen head elevation. The correct answer would be head elevation, sodium, and PCO2, and cerebral perfusion pressure should be 60 to 70. Somebody's mentioned as dexamethasone. So dexamethasone technically can work, but in this setting of raised intracranial pressure, it usually is not very effective. It has not been shown to be effective in acute liver failure. And acute liver failure is associated with heavy level of fungal infections and bacterial infections. So dexamethasone is usually not recommended. But that's a good thought. If you are a neuro center, if you work in neuro places, they would give dexamethasone. But acute liver failure specific setting, it's not very convincing. But obviously, you might be giving hydrocortisone anyways because they may have hemodynamic instability. So it's not proven at the moment. So the best drug to give is hypertonic saline and maintain these principles for acute liver failure. You cannot. It is very unusual for them to have an ICP bolt. They used to do it at King's College Hospital, one of the few centers that used to do bolts in acute liver failures, but they showed that it did not change management. And currently, the monitoring methods include transcranial Dopplers and optic nerve sheath diameters to find if there is raised ACP and to find how they are responding to treatment. The distribution of acute liver failure across the world is quite different because so I'm currently in United Kingdom. I worked in India for about 5 years in liver centers. So you know that the most common cause of acute liver failure in India is viral, and in UK it is paracetamol. So the profile of patients is quite different. But the cause of death remains the same. When you have acute liver failure, you usually die, one, because of cerebral edema, which we have discussed. The second thing will be because of an infection, and somebody, Dr. Anjani, has pointed out that it's amoxicillin antibiotic she wants to give. I think it's very, very conservative to use amoxicillin for somebody for established acute liver failure. So acute liver failure, as we have defined, is jaundice to encephalopathy of more than 7 days. So this jaundice to encephalopathy time without any pre-existing chronic liver disease. And if this has been met and they are in encephalopathy and they do have coagulopathy, then we will have to think about how we are going to treat the bacterial infections. And the best prophylactic antibiotic, if there is no allergies, would be piperacillin tazobactam, which is most commonly used in most centers where patients do come in with acute liver failure. Antibiotics like amoxicillin are usually not used because the level of immunosuppression during acute liver failure is quite massive. So it might not be able to cover all the organisms that they are infected with. And there is usually a very low threshold to start antifungals as well. But obviously, this needs to be managed based on the amount of organ failure and organ support that they need. Yeah, I'm just quickly going to run through the King's College criteria. So when will you refer for a liver transplant for people with acute liver failure? I will not discuss paracetamol overdose. The reason being, I worked in ILBS for 5 years, and they did about 100 transplants every year. And there are a lot of acute liver failures that get admitted there. I have not seen a single case of paracetamol overdose in that period of time. So I don't think paracetamol overdose happens in India. So it's what will be important for us is non-paracetamol. So this is the criteria. You can see if a single value of INR more than 6.5 and any three of the following, that is, if they are very young or older than 40 years, the jaundice duration has been there for more than 7 days. The bilirubin level is more than 300. This will be more than 17 for us in milligrams. INR of more than 3.5. Creatinine again more than I think 5. And etiology of it is idiosyncratic, that is, you don't know why. Is it a drug induced, or it is not hepatitis A and B? This all these means they will do very badly. All these, if any of these criteria is fulfilled, that means without a liver transplant, their chances of survival are very, very low, and these patients need to be urgently referred to a liver transplant center. Now, if you are in New Delhi, a liver transplant center, you need to know which hospital to refer to. There is no government hospital that is doing free treatment for acute liver failure with options for a liver transplant. The only one is, I think, ILBS, but you need to make sure you refer to the right place in time, because in the first 1 to 3 days, the chances of survival with the transplant keep decreasing. So if you have diagnosed somebody with all these numbers and they need to be referred the same day. That is, they need to go to a center that has transplant options, and then obviously they can decide whether they need or not, but it has to be urgently referred. So transplant, again, it happens in less than 10% of patients with acute liver failure. The survival is quite good at 72%, and most failures because of transplant happen because of infection. So that is why I said antibiotics and antifungals are very important early on to make sure they don't end up in infections after the transplant. So transplant is a very complicated process. You don't need to know exactly how it is done, but there are multiple factors that are taken in: whether the patient needs it, whether the patient will survive it, whether there are any comorbidities that are make sure that they will not survive it, and whether they will comply after the transplant. So we've sort of touched on acute liver failure now, the main reasons why they die, how to prevent their death, and what we can do. So coming to chronic liver disease, coming to having complications, that is any hepatitis, severe alcoholic hepatitis, viral hepatitis, leading on to complications. The complication that I will be discussing is gastrointestinal bleeding. Regarding sepsis, acute kidney injury, and bacterial peritonitis, you might know that antibiotics will help. If they have very severe acute kidney injury, renal replacement therapy has been shown to have some benefit in intensive care setting. And spontaneous bacterial peritonitis, again, it is generally a sign of very poor prognosis overall in terms of years, but it can be easily managed with antibiotics if diagnosed early with an ascitic tap. Hepatic encephalopathy, if it is very severe, can be managed with renal replacement therapy, which will clear the ammonia levels. And you can use new drugs called LOLA, that is L-ornithine L-aspartate, which has been technically shown to increase and improve encephalopathy slightly, but it is not of proven survival benefit. And lactulose, rifaximin, the common drugs can still be used, but in an acute setting, they may not help. Patients with chronic liver disease, they will help if you make sure they have the enough stools of at least 4 every day. Coming to what we're going to discuss now is gastrointestinal bleeding. So GI bleeding in a patient with liver disease can be devastating, and the reason that it happens is the cirrhotic liver produces. So the liver is cirrhosed. So the portal vein which is supplying the liver forms collaterals because the blood is not going through the liver properly. And these collaterals go to the esophagus, to the stomach, to the spleen, to the sometimes even to the intestines. So all these varices are these are new vessels, so they are fragile. They engorge, and you can see them on the endoscope. When you put an endoscope in, the vessels are bulging across the esophagus, esophagogastric junction, and this can be seen when you put an endoscope in. So this image, you can see the back pressure going to the vessels and all the veins getting engorged. They have very thin vessels, so they can easily bleed at any point of time. Yeah. So does everybody know what this device is? Can you just name the device for me so that I can know if you know what this is called? Yeah, I just put up on the chat box what is the name of the device. Sengstaken Blakemore. Okay. So Dr. Aarti thinks it's Sengstaken Blakemore. SB Tube, Dr. Ashok Kumar. Any other answers? So I'll just run through this, what you see here. So you can see these pressure monitors. So these are all basically, you can put pressure inside. So you can see the A and B. So the A is the balloon that will inflate in the stomach. B is the balloon that will inflate in the esophagus. And C is the port which will decompress both of them, that is the esophageal and gastric ports. So this is there is a port here, opening here, and there will be an esophageal opening as well, and these two will open here, so that if there is bleeding, the blood will come out through C here. So now these two pressure ports, that is D and G. So these two will inflate A and B, and you need to know exactly what the inflation pressure is. And Dr. Surinder has correctly pointed out that this is the Minnesota tube. This is not the Sengsteken Blakemore tube, because the Sengsteken Blakemore tube has only one aspiration, and this has both esophageal and gastric aspirates, and so it is slightly different, but it's just a technical term. You can use the term Sengsteken, it doesn't matter, because everybody knows what a Sengsteken tube is, and this is what will be there available in your hospital. And this tube is the one that is being used to manage acute bleed that cannot be treated with an endoscopy. That is, that cannot be done banding or ligation. So what do we do when we are faced with an upper GI bleed that is very difficult to manage? Get large bore access, have a low threshold for intubation. There is very high chance that they will quickly have an upper GI bleed, have a hepatic encephalopathy, and GCS will drop as they are worsening, either because of hypotension or because of encephalopathy. So intubating will give you control of the airway, one, prevent aspiration, and also make it easier to do an endoscopy for patients who might be agitated and confused. Insert a nasogastric tube. This is again controversial. In the initial period, it will just used to monitor for bleeding, but it is notoriously poor, so it may not be very useful, but it is recommended. Keep hemoglobin levels not too high, just 70 to 80. Don't over transfuse. Blood numbers, again, this is quite variable across centers. Platelets, fibrinogen, and INR can be targeted. Make sure you're checking the fibrinogen levels, because it can sometimes be missed and you might not give cryoprecipitate when they do need it. And endoscopy, early versus late, it is ideal within the first 24 hours, but it does not need to be in the first 6 hours, and it should not be when the patient is hemodynamically unstable. That is, the patient has to be stabilized either in ward or in intensive care prior to the endoscopy. You do not do a crash endoscopy. So make sure they're intubated, they have maybe a central line, arterial line, blood pressures are controlled, and then they need to go for an endoscopy, rather than do the endoscopy and then manage the hemodynamic instability. Terlipressin, somatostatin, and octreotide are all recommended. They all have equivalent outcome benefits, so they can all be used. In our center, we use terlipressin mostly, but each center will have their own preference. It does not matter, because each of these options have the same benefit. For example, in America, they do not have terlipressin, so they use mostly somatostatin and octreotide infusion, and they have had similar outcome benefits with upper GI bleed. Again, this is the SB tube, which I've explained already. So for those of you who have not used the SB tube, it is very easy to use. Indication is basically when endoscopy and everything else has failed for a variceal bleed, you put this in, inflate the tube, inflate the balloon, inflate it to about 50 ml of air, check with an X-ray, and then increase to 250 mils. If the SB tube fails as well, then you have to do a CT angiogram, and sometimes the CT angiogram can pick up a bleeder, a small bleeder from one of the varices, which can be directly embolized by a intervention radiologist. So you need to make sure you send to a center which has intervention radiology, which has an endoscopist on call, and which has these options available if you have a refractory upper GI bleed. The third option for refractory bleed will be a TIPS. So a TIPS is basically a shunt. As many of you might be already aware of, you can see this. This is what the TIPS procedure does. So the intervention radiologist will go through the right neck, go to the superior vena cava, right, then the inferior vena cava, and then they'll go to the hepatic vein here. So here they'll put a small hole in the hepatic vein, connect it to the portal vein over here, and then pass a small sort of shunt that will shunt the blood from the portal vein to the hepatic vein, bypassing the liver. And this will decrease the pressure on the portal veins, whose back pressure is causing the upper GI bleed. That is, the back pressure from the portal vein goes to the gastroesophageal varices and then causes the bleed. So now the blood is diverted to the hepatic vein, and this will decrease the variceal bleeds. But this is a rescue procedure where when everything else fails, this can be attempted. And this is just one of those things that can now be used to manage the coagulopathy of bleeding, where once you have coagulopathy, you may not be able to manage just with platelets, fibrinogen, and INR. So you can use a thromboelastogram, which can be used bedside. It is similar to a blood gas machine. So you put the blood in, it will tell you these numbers, and these numbers are increased for different factors. For example, if the R time, that is the initial time to start the clot, is a problem, it is because of the coagulation factor. So you have to transfuse FFPs. If the K time, that is the time taken, you can see the clot forming here. It's basically a graph. It will become big and then maximum clot strength, and then it will start fibrinolyzing. So the time taken for this is because of coagulation factors. The time taken to reach the maximum is because of fibrinogen, and the time to reach maximum amplitude and then fibrinolyze is because of platelets. So when each of these is deranged, you can give different products. So if the first part is deranged, you can give FFP. The second part is deranged, you can give fibrinogen. If the maximum amplitude is deranged, you can give platelets, and this will help in guiding therapy. So that's how the TEG machine looks like. If you have patients, a lot of patients with acute liver failure, it will benefit if you have this machine. So yeah, that's the end of the presentation.